Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you are spending this hour with us, and we are very fortunate today to have a speaker addressing a topic that is extraordinarily underserved by the medical profession and maybe unknowingly not pursued by everybody, even members of the professional community. So hope that was a good teaser. Without further ado, I'll turn it over to Dr. Randall Maxley, our founder.
Thank you very much, Dr. Barbara Davis Stevens. We do indeed have an interesting topic today from a young lady that I met at a program for seniors several weeks ago, and she's agreed to give us our talk for today. But before we get started, I'd like to ask Reverend Dr. Ivan Walks to give a special prayer for the island of Jamaica, which is under immediate threat from a major hurricane expected tomorrow to be a level 5. Dr. Walks?
Thank you, Dr. Maxey. I am not an ordained reverend. I am an ordained counseling elder, and I'm happy to provide an opportunity. Every opportunity for prayer is one that I welcome. So let's pray. Dear Lord, Heavenly Father, Lord, we thank you so much for so much. We thank you for opportunities to love and to care. We thank you for opportunities to worry because it knows that we have feelings and that we care about each other. So this afternoon, as we think about and talk about our brothers and sisters, some who we know well and some who we don't know as well, on the island of Jamaica, the island of Hispaniola, who are facing a Category 4 threat from Hurricane Melissa. We pray that you will just reach down and touch every single head and heart and keep them as safe as your plan makes them to be. We are thy will be done prayers, and we are praying that your will is for those folks down there to be safe and happy. We pray and ask all of these things in Jesus' name. Amen.
Amen.
Thank you so much. I know how these hurricanes can be. My last visit was to Puerto Rico in 2018, and they had Hurricane Maria, and the level of devastation is unreal, with uprooted trees, houses thrown down mountains, and it made you cry to see was there, and the electrical grid went out. So they're worried about communication that happens in Jamaica after this is over. So we need to keep that in prayer, and I'm sure there'll be need for those of us who can to donate and give to help our brothers and sisters there. We pray for our sister, Dr. Lisa Dawes, who I spoke to this morning, and she is quite concerned. And there's a mental health concern also, Dr. Walks. A lot of people are calling the government. They're afraid for their safety and their children. But now let me move to introducing our distinguished speaker this morning. Her name is Dr. Tamara L. Dixon, DDS, Doctor of Dental Surgery, and she deals with oral health and wellness, and as well sleep health and wellness. And she's located here in Los Angeles on Sepulveda Boulevard. So Dr. Dixon is a cosmetic and wellness dentist. She's been in private practice in the LA area since 1994, the year I was born. She's also known for using the highest standard of care and most current techniques in delivering aesthetic dentistry for her patients. She specializes in oral systemic health, dental cosmetic procedures, orthodontics, and orthopedics, and dental sleep medicine. I'm going to ask her about that. I don't know what that is. And she deals with sleep apnea. She also provides advanced antimicrobial periodontal treatment with an emphasis on improving overall systemic health. And what we've come to learn is that the oral cavity affects your mind, it affects your cognition, it affects your heart, your blood pressure, and your brain. She got her BS degree, bachelor's degree from the University of Southern California, and she attended dental school at University of California at San Francisco. She received a doctorate in dental surgery then, as well as a bachelor's in dental science. She's taken extensive continuing education courses in orthodontic, orthopedic treatments, dental cosmetics, dental implant restorations, periodontics, and sleep apnea. I need to go see her real quick. So she also took a sabbatical from a private practice to dental research. And during this time, she was a full-time traveler across the United States dealing with oral health. She also was an examiner for the CDC and for NHANES health, which we and nutritional examination, which we quote often. So I bring to you now, for your listening pleasure and learning, Dr. Tamora Dixon. Dr. Dixon, the floor is yours and welcome.
Thank you so much. I was thrilled to be here. I didn't know that it was going to be like on YouTube and stuff like that, but I'm so excited to share this information anytime I can get a chance to do it with physicians, especially. I would go around and take photos to physicians and try to explain about oral systemic connections and stuff like that. And a lot of times they would just say, well, you know, my patients have Medicare, or they don't, they can't come, or, you know, I don't know. I don't know what it is, where the disconnect is, but we're going to connect it together and get this bridge going. The American Heart Association suggests that you do have someone in the dental profession that you can refer to that knows about biological connections. So as Dr. Maxey said, I'm in Westchester on 8610 South Sepulveda Boulevard, and that's on the corner of Manchester and Sepulveda near LAX. And this is my information here, my website, and my email address. I'm gonna do can you guys see the slides?
Yes.
Okay.
We can
So
see
the first
them.
thing I'm going to talk about is
Dr. Dixon, can you hit the slideshow button? Then it'll be a little bit bigger for us.
okay. Okay, there
So
you
the
go.
one, here we go. Yeah.
Thank you.
Mm-hmm. So the first slide I want to talk about is one of the main things that we find dental bacteria everywhere is from gum disease. So when you have inflammation around your gums, a lot of people will have bleeding gums when they brush their teeth, or their gums will be swollen and feel thicker and redder. And so those the bacteria that's in there travels throughout the body, and they find them in all kind of diseases, from heart disease to rheumatoid arthritis to pancreatic cancer. I mean, there's a lot of different diseases that they find this bacteria in. This bacteria is different in everybody. It's just like DNA. So it's different in everybody. We have tests that we do to see which ones you have and how aggressive it is. Some people don't have bacteria that's really aggressive, so they won't lose a lot of bone. And some people just lose a lot of bone and it'll be aggressive. And whatever it's doing to the gums, it's doing inside of your body as well. So it doesn't stay in the mouth. It's an infection. Like people will say, oh, I have gum disease, but they don't realize that it's an infection that affects your whole body. There's research that shows that it's a bidirectional relationship with periodontitis and diabetes, for example. So when people have bleeding gums and diabetes, if you clean their teeth and get rid of the bleeding gum, get rid of all the infection, then the diabetic marker goes down. And that's some insurances now even cover to get 4 cleans a year because it cycles with the diabetic marker. So that would be like right in here. You could see where it's swelling, where the gums would be bleeding at. You can see the changes in the tissues right here. And then after it's cleaned out, you can see how clean the roots look. They have bone loss. You can't get that bone back. It's just gone. But when the bone is eating, this is like maybe 50% bone loss down here, or a little bit more. But when it gets to like 75%, the teeth are really loose. They just sometimes fall out on their own. That's how bad these infections are. And infections where if people have toothaches, then those type of infections are a little different because the infection is at the tip of the root. And those infections are found a lot in heart attacks. And I'm talking high, like 75%. So it's important that you ask patients or ask your doctor if you're the patient, but if they should ask you, do your gums hurt? Or do your teeth hurt? Do your gums bleed? Are you chewing your food comfortably? Especially the older that you get. This is another one where it shows like crowns on people's teeth. When you have crowns on your teeth, it's a 360-degree barrier between that tooth and your gums. So a lot of times if that crown isn't fitting totally 100%, you're going to be getting swelling in between the gum. You'll be getting bacteria here. And if you're not cleaning it well, if you're not flossing properly, most people don't even know how to floss properly. I'm going to say 90% of new patients, and I don't care if they're 10 to 90, they've never been shown how to floss properly. 90%. So if they're not flossing properly, they're not getting the bacteria out while it's soft. So when you brush your teeth in the morning, you're getting the bacteria off when it's soft. If you don't floss, you're not getting it out from under the gums while it's soft. So it starts building up more and more and turns into tartar, which is bacteria that is very deadly to the body. But as you can see, these people will have more tendency to build up bacteria because of the interface of the crown and the gums. This is a advanced periodontal case. So you could see, like this person, you can see all around the gum line, you can see tartar. All here is infection. And this is the same type of infection that you would go to the doctor for. So I always tell patients, if you wash your hands and they bleed every time you wash your hands, then you would be running to the doctor. Like, what is wrong with me? I'm bleeding every time I wash my hands. They bleed every day and they do not go to the dentist. And it's the same infection. It's going to do the same thing that it would do to your diabetic marker or your heart attack marker or anything. If you have an infection, an infection is an infection. So all of this is tartar, and you can see how the gums are pulling away from the tooth. You have inflammation here. You have a lot of tartar here. So when we clean that, we're going to see the root because it's already eaten all the bone away from that tooth. And it's a silent disease. People don't even feel it. But like something like this, they might have a mouth odor, and that would mean they need a deep cleaning. And so when you do clean it all off, you could see root area here. You could see this tooth, period, because on the previous slide, you can't even really see the tooth because there's so much swelling there. So you already know, I can look at this and tell how much shrinkage I'm going to get, how much bleeding, how much infection is there, and what we need to do to clean this. The problem that we have in community clinics is that they don't do this. They don't clean these teeth. They will polish this and keep on going. When I got back from doing research in 2013, I went to a clinic and I was like, I'm going to give them some private care and see what happens. So when I interviewed with the director, he didn't even know. So it's a problem with not only medical, but dental as well, because dentists don't even know what this stuff is doing to the body. So it's a real big disconnect. But I told the director, and it was 8 clinics at the time. I said, I don't polish bacteria. So I'm going to tell you that right now. And he was like, oh, well, our plans don't really cover for deep cleanings. Like, how you don't cover to get rid of infection? A cavity is an infection as well as a bacteria is an infection. We get rid of that. So why wouldn't you get rid of this infection? And he says, well, most plans don't really cover it. So we just don't do it. There's no such, and I told him there's no such thing as a regular cleaning when they have all this infection going on. You can't just clean the surface and leave the infection that's, killing them. And so 2 days later, because I know he wasn't telling the truth, but 2 days later, he gave a message to all of the dentists and told them that they have to start doing deep cleaning. Start. That means these people, it was heartbreaking. When I saw these patients and compared to my patients, it was like night and day. My patients looked like privileged people compared to the people in the community. It's really, really sad. It was to the point where I could tell people that they were diabetic. I'd be like, are you diabetic? They'd be like, oh, how did you know? I'm like, I could tell by how their gums would bleed. I could almost touch the gums and they would bleed. And so it's really bad. But the doctors were mad. They were like, I don't know why all of a sudden we got to do all these deep cleanings. So it was, but they didn't know it was me that made them have to do it. I don't know if they still do it because I haven't done that in a long time. But it's something that needs to be. It's a concern. It's a concern of mine, and I just want it to be public knowledge. So that's my whole goal, is that this oral systemic connection is public knowledge, and people are aware, and they're aware of what a good cleaning is. I had a woman come in the other day, and her teeth were not bad. She had been getting cleanings and stuff, but she had stopped a little bit, after the pandemic or something. But she's a good flosser because she had braces before. So when I cleaned her teeth, she was like, "Oh my God, I never had a cleaning like that." And most of my patients will say that, because it's not a 15-minute cleaning. When you work at the clinics, it's like 20 patients a day. There's no way you could do this cleaning in 15 minutes. So this would take like 2 hours, and sometimes 2 appointments. But with the clinics, they would give them 15 minutes per quadrant. So they would have to come back 4 times to get this clean. That's the clean. Okay, the bacteria testing that we were talking about is something that you could do actually in your office as well. It's called oral DNA, and it's a 30-second rinse. So you swish around the saline in the patient's mouth for 30 seconds, swish, gargle, swish, gargle, swish, gargle, spit, and then you get a reading of these 11 different bacteria. And there's a lot of research on these bacteria. These high risk pathogens, these lines right here just tells how much you have to have for it to start eating your bone. But it doesn't say, because the research is so, it's not a amount on how much it takes to, harm the body. But you have this much, it's eating bone, so it's doing harm in your body. But so this would be like a test that we did, and we'll say, "Oh, you have this is highly related to dementia, you better get this one down," that kind of thing. And some of them are like in your body, so you would not totally get rid of it, but you can get it really low. This would be like an 8-week follow-up, and you can see some of them they still have, but for the most part, a lot of them are just totally gone. And that's an 8-week follow-up after their deep cleaning. Well, I don't want to end it. So this is like a report that I would give them, but now the report actually comes on the test, but it doesn't have some of the research on there, but it does have like generalizations on there. So it'll say like this one is found in aneurysms, heart disease, dementia, Alzheimer's, diabetes. This one is found in rheumatoid arthritis, heart disease. Like a lot of times you'll see a theme, like you have a whole bunch that say rheumatoid, and that person will be like, "Yeah, I have rheumatoid." And there is studies that show that rheumatoid arthritis, some people think it's 100% triggered by oral bacteria, because they find oral bacteria in 100% of the synovial fluids in the joints of rheumatoid patients. So you can see different cerebral aneurysms. This is rheumatoid, Alzheimer. Some of this is like bacteria that you would find in your mouth anyway. But at certain levels is when it starts getting destructive. So this was an event that I did. So I just put this little slide in there about breast cancer and breast cancer awareness. And 1 in 8 women will develop invasive breast cancer. 1 in 2 American adults have some form of gum disease. That's half of the population. So half of the people are going to get some type of gum disease. Sometimes it even just comes like in menopause, where all of a sudden their gums are bleeding, their teeth are shifting. They're like, "Oh my God," and we have to get on it. Women with gum disease have a 14% increased risk for breast cancer compared to women without gum disease. There's a 30% risk for women with gum disease who smoke or smoked in the past 20 years. So gum disease and smoking are bad for everything. You guys already know smoking is a confounding factor of everything, basically. And this one, okay, we're going to talk about sleep apnea a little bit. There are appliances that we make for sleep apnea, and they're called oral appliances for sleep apnea, or oral OSA appliances, or MAD appliances, mandibular advancement. So the difference between an oral appliance and CPAP machine is that the CPAP machine forces air into your airway. The sleep appliance opens up the airway, so it's no forced air going in. And with mild to moderate sleep apnea, which would be a AHI of 30 or less, they can get an oral appliance right away, and most medical insurances will pay for that. We're signed up with Medicare and all other major carriers for the sleep apnea appliance. So the AHI is when someone stops breathing for 10 seconds or longer. That's one AHI per hour. So there's people that stop breathing for 10 seconds or longer 30 times an hour. They would be severe. 15 times an hour, there will be a moderate sleep apnea patient. There's people, I've seen one test came through and hers was 81 times an hour. How do you stop breathing 81 times an hour for 10 seconds or longer? And I've seen some, they stop breathing for like 50 seconds. And that's when they'll start gasping, like people that sleep and gasp. And so they really need to see someone and get tested for sleep apnea right away and get an appliance or a CPAP machine. So as you can see, sleep apnea, they have a higher risk. It's the same thing it's almost the same thing like gum disease. They have a higher risk for heart attacks, higher risk to develop diabetes, the higher risk for obesity, anxiety, so many things. Sleep apnea is another, so you're not getting enough air in your airway, so it's leading to not dementia so much, but like forgetting things and stuff like that, brain fog, that kind of thing. So gasping for air, nightmares, insomnia, these are the signs that they would have. Anxiety, depression, chronic fatigue. So somebody that's always tired, they wake up and they could take a nap again. They fall asleep. Some of them even fall asleep at the stoplight. So that's one of the questions on the Epworth test. So what we're trying to do now is to get more physicians to screen patients for sleep apnea. In New York City, they just passed an ordinance where every resident gets a free sleep test because they know it's so underdiagnosed. And it's so, they need to see how, this is another risk factor that doctors don't check, and they should. And so there's easy ways to do it. There's the Epworth test, which is the most common one, but the stop bang test is the more reliable one. So research shows that this one, if they answer questions on the stop bang test, if they get 3 or 4 yes responses, then there's more than likely they do have sleep apnea, but they would still need to take a test. These are other consequences of sleep apnea. It increases your risk of stroke, asthma a little bit. There's 38,000 cardiovascular deaths annually, hypertension, 39%, coronary artery disease, 30%, congestive heart failure, 140%. So when people like die in their sleep and people think, oh, that was really peaceful, they died in their, they suffocated. So it wasn't peaceful. But one of the things that when you get sleep apnea treated is some of the weird things, well, I would say weird, but things that you wouldn't expect is this one, frequent urination at night. They will stop going to the bathroom. So they'll be like, oh my God, I used to go to the bathroom 4 times a night, but since I started this appliance, I don't go to the bathroom anymore. So they're resting and they're getting the cellular healing that they need to get during the night, during sleep. So a lot of these are loud snoring. That's a sign of it. Mood disturbance. You know, somebody always evil. They probably just not sleeping good. Loss of alertness, daytime sleepiness, diabetes is another one. And of course, obesity. So this is a stop bang. And this is what is your sleep apnea risk? And do you snore loudly? Are you tired? Do you feel tired, fatigued, or sleepy during the day or when driving or talking to someone? Um, One of my patients, she was like 28. She's been coming since she was born, basically. And I had her do this. And I had her do the Epworth because they asked you to fall asleep at a traffic stop or something. And she said, yeah. I'm like, what? She's like, yeah, sometimes I'm on the freeway and I just feel the bumps and I wake up. And I'm like, oh no. So first of all, you need to stop driving until you get this taken care of. But funny thing is that now that I think about it, she had a stroke a couple of years ago. She was at work and she felt like she was going out. She called her dad, and her dad's like, "Go to the hospital." The hospital was right across the street, and she had a stroke. But they said it may have been related to the birth control she was taking. But now that I'm thinking about it, with her telling me this, it could be related to her sleep apnea as well. So another one is, do you have high blood pressure? Now, one of the things that is a red flag is resistant hypertension. If someone has resistant hypertension and they snore, they need a sleep test. So that's the only exception I would put on here, that it would be 2 things instead of 3, because resistant hypertension, there's a lot of studies on that, how it is related to sleep apnea. The body mass index, age older than 50, neck size. We measure the neck size. We have, the measurement for the neck, but men usually know theirs because they know their shirt size or whatever. And gender, male. So you're low risk if you answer 0 to 2 questions, intermediate risk if you answer 3 to 4 questions, high risk if you answer 5 to 6 questions, or yes to 2 or more plus male gender. And I would say two or more. They said 2 or more plus BMI over 35, but they asked you that already, BMI over 35. 2 or more and neck circumference, they asked you that too. So, but I would say 2 or more and resistant hypertension. So untreated sleep apnea can increase your risk for heart attack, stroke, high blood pressure, diabetes, obesity, driving accidents, and death in your sleep. So this is our number that we use for the sleep apnea business. And it's in the same office, but we do that on we do that on Wednesdays and Fridays. So anybody have questions?
First of all, thanks so much for this. I learned a lot, especially about resistant hypertension, doctor. So you've taught us a lot. Thank you so much.
You're welcome. If anybody wants any research or anything like that, I have tons of it. If you want me to send a packet to your office, I can send a packet because I do that. I gave Dr. Maxey a little sample one when I met him.
Okay. Well, let me ask you the first question. Talk about this resistant hypertension. I'm a hypertension doctor. I'm a nephrologist. I have a lot of people who are very resistant, so I should order a sleep test for them?
Yes. Yes. So we can come over and talk to you about that. We could do a lunch and learn and teach your staff how to screen for that and get you set up. You can actually, we have people that you can refer them to get the sleep test, and you just have to write the prescription for it. Okay. So I can get you the materials that you need to do the prescription for it and get their test results back. And if they need a oral appliance, then the letter of medical necessity will say oral appliance or CPAP machine.
Okay. Let me introduce you to our co-moderator. Dr. Barbara Nave Stevens is a pediatrician. She alternates between Florida and Memphis, Tennessee, former.
Hey, Phil.
And we have Dr. Ivan Walks, who's a psychiatrist in Washington, D.C., former chief health officer for the city of Washington. And we also have Dr. Jocelyn Hines, who is a family practitioner in Maryland and head of the Family Practice Association there. So, Dr. Neighbor Stevens, do you start questions and discussion?
Thank you so much. I would like for Dr. Dixon to give the audience 5 takeaways. There were 1,000 gems in this presentation, and we thank you for that.
Yeah,
but give the audience 5 takeaways.
Number one, your gum should not bleed. It's an infection that affects your whole body. Number two, try to do a dental visit at least 2 times a year. If you're over 60, I would say 3 to 4 times a year. Number three, if you snore or have a lot of fatigue, talk to your physician because they need to order a sleep test for you. Or if you have any other of the other symptoms like heart disease, have had a stroke or anything like that. Number four, daily brushing and flossing will extend your life. So there's studies that show that people who brush at night live longer. So brush in the morning and at night because you want to get that bacteria off and make a smooth surface to where bacteria won't adhere to it. Because the bacteria comes in it's in your saliva. So when you're asleep at night, if the saliva is bathing around in your mouth, you wake up with a bad breath or sticky teeth. You have to go brush your teeth. That's the tartar that builds up if you don't get it out from under the gums. And then another one would be try to save as many teeth as you can because people who have the more teeth you have, also the research shows the longer that you live, the more healthy teeth, the longer you live.
I was told only floss the teeth that you want to keep.
Right. I've heard that too.
Dr. Walks.
Dr. Dixon, I am really, really excited about this presentation for two reasons. One, many years ago, I was standing outside with a friend of mine whose father was a dentist, and we're having a good conversation. He says, "Man, you gotta clean your teeth." I'm like, "What are you talking about, man? I brush all the time, brother. What are you talking about?" He said, "Look, you got to go clean your teeth." So I appreciate people telling the truth. And I think when folks care about you, they will tell you that your teeth need to be clean or that your breath needs a little bit of help. The second thing I want to say is that I remember when I was health officer in DC, there was a little boy who went to the dentist because he had an infection in his mouth, and he didn't get good care, and he wound up dying because people don't really understand that infections in the mouth are infections in the body, and that infection tracked back to his brain, and he died. So I think this is so important. I worked at the California Dental Foundation many years ago, trying to improve understanding about the importance of dental stuff in general healthcare. And I'm overwhelmed. What you said was delivered so clearly, so easy to understand, so relevant to everyone who has a body. You presented something really relevant to us. So I guess my question is, what's a good toothpaste? I'm an old person now, so I use the Sensodyne stuff. And should I go back to the Colgate I used to use when I was growing up? What's a good toothpaste?
I think that Sensodyne is good, but I don't really have a preference as far as toothpaste goes. I would just like for you to brush. I think that as far as the infection goes, peroxide. Peroxide is the best thing that you could rinse your mouth with. All these fancy mouth rinses out there, peroxide really eats up the infection. We have a treatment that we do called Perio Protect, and it makes trays that get the peroxide gel down into the socket where the pocket is and eats up that bacteria. And so I have patients that have been on that for 20 years now, and their gums are more healthy than they were when they came to me 20 years ago. So peroxide is the best rinse that someone can do.
Thank you so much.
Any toothpaste.
Dr. Hines?
Well, just thank you again, Dr. Dixon, for just a profound and frankly very scary presentation. One of the things, there's several things that really stand out to me. So I'm going to ask my first is actually my doctor question.
Okay.
What I have not come across anyone that I can think of with your credentials, right? So what would trigger or should be a flag to me to try to find or refer to a person such as yourself? Like what would those things be from the doctor side, like from the body side?
There's an organization called American Association for Oral Systemic Health, AOSH, and it puts physicians and doctors together with the research and everything. They have conventions and everything. So on their website, they should have doctors listed or dentists listed that do biological dentistry, like I do. But like, everybody don't test bacteria and stuff like that.
What kind of should I think about? Like, maybe you would benefit from seeing.
Well, first off, you should in your intake forms write a dental history. We have medical history and dental history in dental. You guys should have dental history in your intake forms. So I would say, even if it's just 3 questions: when's the last time you've been to the dentist? Do your gums bleed? Do you have any toothaches? And then when you look at their heart attack markers, their diabetic markers, stuff like that, if any of that is high, they need to go to the dentist. And so just say, hey, you need to go to the dentist. And if they have a toothache or anything like that, or their CRP levels are really high, send them to get a full set of x-rays where we can see the roots and everything. Because if it's a tooth with an infection at the root, it probably needs to come out. And that'll make that CRP level go down.
Can you talk about a CRT a bit more?
The HSCRP, that's how much inflammation you have in your body. And so that's usually on blood tests, I believe, like standard blood tests. Yeah. So you can see if that level's high, they probably, if there's nothing else going on that you can see, they probably need to go to the dentist. They either have bleeding gums or some kind of dental infection going on.
Yes. I think Dr. Hines had a second question. Dr. Hines, didn't it?
Yeah, so my second, and there's a bunch of questions in the chat, but my second question is one of the things that you hear very commonly about why people don't go to the dentist, especially after they haven't been for a while, is pain and discomfort. So how do you talk to folks about the pain and discomfort? And, to your point about honesty, realistic expectations.
Well, usually I would tell people.
Oh, no.
I asked a horrible.
Yes, Card, is the doctor still on with us?
No.
She lost a connection for a minute.
Okay, maybe she'll come back.
Maybe she will. You know what? While we're waiting for her to come back, Dr. Lawson is on, and I think the comment about oral health and mental health really struck with me, and I wonder if Dr. Lawson has more information or has done some research on that, since he's done research on everything else.
Okay, Dr. Lawson, how are you?
You unmuted.
Okay. Yeah, just want to note, full disclosure, I'm a sufferer from sleep apnea and also narcolepsy, and actually worked and did sleep research back in the older MENTS group. One of the things that we found is that, of course, sleep apnea is strongly related to depression. I've taken people off antidepressants once they've gotten the CPAP and it was diagnosed. And I hope that Dr. Maxwell have a whole session on sleep, since that's the longest single activity for most of us. And with the research and the recognition by physicians is small. Also, I really enjoyed her discussion in terms of the linkage to dementia as well as to auto accidents. Frequent cause of auto accidents, although it's grossly under-recognized because if the person doesn't survive, we can't get good history. In terms of the relationship to dementia, in addition to the obvious effect of hypoxemia to the brain, there's also some strong evidence that show that some of those toxic bacteria, as you mentioned, is associated with development of amyloid plaques. There's some controversy about it, but the bottom line is the relationship with dementia is extremely strong.
Thank you. Simon, let us know when she comes back on. She lost her connection. Her computer died. Are there any other comments in the chat?
Well, we got some good questions. I really wanted to hear her answer. Well, I don't know what's the difference between an electric toothbrush and a battery powered. To me, they're both running by electricity, but I wanted to hear the answer to that. And I've never understood this oil pulling stuff. So I wanted to hear her comments about this.
Yeah, I want to hear her comments about these implants, teeth implants. What that does.
She's back. She's back. She's on mute. You're on mute.
There we go.
Okay.
Welcome back, Doctor.
Thank you.
Yeah, a lot of discussion while you're going. We all have more questions. We're waiting on you.
Okay, keep going. So you want to talk about implants?
Yes.
Implants, oil pulling, and the difference between an electric toothbrush and a battery powered toothbrush.
Okay, I got answers for all that. Okay, let's start with the oil pulling. I like oil pulling because it does attack the bacteria. And let me tell you guys something.
What is oil?
Can you hear me?
Yeah, what is oil pulling?
Oil pulling is when people put like coconut oil, it's usually coconut oil, in their mouth and swish it around for as long as they can and spit it out. And it kind of attacks that bacteria, right? And so the thing about coconut oil, it is an MCT, which is a medium chain triglyceride. And medium chain triglycerides from coconut oil are found to also help in dementia patients. And it makes sense because 86% of dementia patients have dental bacteria in the area of the dementia. So when they do the autopsies on them, they find 86% of them have dental bacteria. So when people take the MCT oil, and you can find it everywhere, like take a tablespoon of MCT oil a day or 2 tablespoons, and they'll start clearing up. One of my patients told me about it. Her mom had dementia, and they basically sent her home and like nothing we can do. She hadn't spoken in months, and she saw this TED talk about it, and she tried it on her mom. And one day, like 3 weeks later, her mom started singing Amazing Grace because she used to sing in the choir. And then she asked her mom her name. Her mom knew her name, and she knew her name. So another time, my grandmother's sister, she was probably like 94 at the time, and she was getting, I don't know if it was forgetful or what, but I know she started kind of talking like a baby. I'm like, what is wrong with Aunt Georgia? She never does that. And they were like, oh, I don't know. I think she's getting dementia. So I made them start taking MCT oil. And within 3 weeks, she was back to her normal self. And her caregivers that were coming over were like, what did you guys give her? Like, what happened? And they started taking pictures of the bottle of the MCT oil. And it says on the bottle, brain health. If any of you know of it, but it's really good for, I think, dementia patients.
You mean I don't have to see Dr. Walks anymore?
But it makes sense because oil pulling helps that bacteria not to build up. So you figure if you're ingesting it, it's probably going to the brain where it's causing a problem and eating that up too. I don't know, but it worked for my aunt.
So what is the preferred thing? To take a tablespoon every day or swish it in your mouth and spit it out?
Well, you're supposed to swish it in your mouth and spit it out, but I would swish it in the mouth, spit it out, get another tablespoon and swallow it. If I was thinking I'm going to have dementia problems, you know? And what was the next question?
Implants.
Oh, what about implants?
I have a lot of patients that have total implants. Is that healthy to get your?
It really depends because I was at a implant meeting one day and the doctors were talking about, oh, these implants, sometimes they fail, but now we got this new thing where they put some crushed up flagell in the bone graft, and there's no holes in the bone graft. Like it takes perfectly. And I'm like raising my hand. That's because they had bacteria that eats the bone. That's why the tooth came out. So if you put an implant in an area where there was bacteria that was eating the bone, then you're not going to have as good a result. So the thing about it is, why did you lose the tooth? And what are you doing to heal that bone before you put an implant in there? So that's why the flagell was working, because it was an antibiotic put in with the bone graft. So it was clearing up the infection at the same time. That's why the bone grafts were taken better for the implants. But I like implants. I think that they're really good. There's an implant robot now that can do the implants. So I'm looking into that. But I like implants, but it's more to it. And a lot of doctors, like I said, they don't know about these oral systemic connections. So they're just thinking, some of these implants take and some of them don't. But if you have the right environment, then they can be for life.
And what about the electric toothbrush versus the battery powered toothbrush?
Both of them are pretty much the same, honestly. The electric toothbrush and the battery powered are pretty much the same. But it depends on like what brand you have and the way the toothbrush is shaped. I like the round ones better because they're more like what we use at the dental office to sweep around the tooth and get bacteria out. But the thing about the toothbrushes is when you have a toothbrush, a manual toothbrush, you're usually putting pressure on it. So some people that have manual toothbrushes, have power toothbrushes, put pressure on it, and that could damage the enamel. So you want to be careful when you do have electric toothbrushes, you're not pressing hard on the tooth because it can wear away the enamel. And I've seen it.
I think Julianne Taylor had a question, a comment.
Her question is, are zirconium dental implants better than titanium dental implants?
I think that titanium have the most or studied the most. The zirconiums are kind of newer type of implants, but I know they make the zirconium crowns on top of the titanium too. So most of the restorations, if it's like a bridge, it would be like the zirconium would be the crown part, because the implant is 3 parts. It's a screw that goes into the bone, then an attachment to that screw to put on whatever you're going to put on. If you're going to put on a crown, or you're going to put an overdenture on there to click in. So it's like a 3-part thing.
Okay.
They're all biocompatible. They're all pretty biocompatible.
There's also a question about does a root canal deal with the infection, or would resolve the infection?
Most of the time, yes, root canals do resolve the infection. So when you get an infection at the tip of the root, it's called an abscess. So that's when people can't chew because it hurts to chew because there's a bubble at the tip of the root. And so what the root canal does, it goes in and cleans out the source that is causing that, which is the nerve and blood vessels in the canal. So they clean that canal out and the infection resolves. What we do usually is give an antibiotic first, because I don't even want to go in there while it's hurting, because the abscess will block the anesthetic from getting to the tooth. And so that's why a lot of people are afraid of the dentist, because they may have had a bad experience with that, because some dentists will just jump in and do the root canal and not get the patient comfortable first. And then a lot of times when you do get the patient comfortable first, they won't come back. Oh, it doesn't hurt, so I'm not coming back. Then 6 months, a year later, it's hurting again. But at that time, the bacteria that wasn't killed is multiplying. So now it's harder to control this infection. So it's important that the patient understands that this is temporary to get you out of pain so that you can come in and get the work done comfortably.
Let's take another round, Dr. Walks.
I continue to be like Dr. Hines, afraid and overwhelmed. This is a lot. There's a lot of information.
And I have a
And
lot more. This is a little bit. This is just a little sample.
I need Dr. Maxey to share the packet that you sent him because this is so important. When your computer went down briefly, Dr. Dixon, Dr. Lawson was talking a little bit about the mental health aspects and the depression treatment and what have you. So this is just so relevant to everything that all of us do, and I'm disappointed that this isn't a more prominent part of general medical training for doctors, nurses, for everybody. It really is challenging. Let me go back to the coconut oil pulling, something I had absolutely never heard of. Somebody put in there, how much is it? I looked on Amazon, you get 32 ounces for like $16. So
Mhm,
it is affordable. I'm going to order
mhm,
some.
mhm.
So just in terms of sequence of events, I understand maybe a pre-rinse, some brushing, some flossing, some other rinse, because that's what I do. Where does the coconut oil fit in? Do you use that last after everything and the spitting
Um,
and then swallowing?
it depends on the patient. I think that they use it after they brush.
Okay.
Yeah, I think they use it after they brush. But I
Okay.
I would say brush, floss, then rinse because then you're rinsing all this stuff out.
Okay.
Brush, floss, rinse. And the coconut oil could be part of the rinse as well.
So I came up in the old days when we had Buckety Beaver and New Ipana toothpaste, and they showed how to brush these teeth, but they didn't have flossing back in the day when I was coming up in school.
That's
So
right.
we might need somebody to give us a lesson in how to floss.
I would definitely do that. But it used to be called pyorrhea. So the doctor, when I first started, I was working with an older doctor Moore, and he was on the east side, and he was saying he had some convalescent homes. So we would go out there like on Wednesdays and work on the convalescent people's teeth. And he would say, "Oh, go ahead and just polish their teeth." And I was like, "Dr. Moore, they need a deep cleaning. They got tartar." And he would say, "Okay, whatever." Because they didn't learn anything about cleaning it out. They would just tell patients, "Oh, you're going to need dentures one day," when they see all of the infection, but they didn't know about cleaning it out. But these oral systemic connections, there have been research going on. The oldest one I found was 1900.
Hmm.
I found a lot in 1916. I mean, they've been knowing this. So I don't understand why it's not. The only reason I think is because it's not on the boards. It's not on the medical boards. It's not on the dental boards. So if it's not on the boards, they don't teach it in school. So I think if
Wow.
we get it on the boards, hey, then they would probably teach it and people would know.
So, Dr. Dixon, I know your focus is geriatrics or senior adults, or however way you want to describe
But it's
us.
everybody, it's everybody,
Um,
but I do focus on them.
but I am a pediatrician, and if you would just give us a word on what parents need to try to do to help their kids wind up in adulthood with good, healthy mouths.
Go to the dentist early. Go to the dentist early. My kids that come in have been coming since they were young. I don't have a lot of little kids anymore because most of my little kids are having kids. So, but the earlier they go, the better because they're experts. I mean, they judge people and everything. It's like you can. They are serious about their oral hygiene. All the kids
Well,
have ever come to me.
What age should
well,
they start?
pediatricians are
I
taught that
agree.
they should begin their dental visits when they have teeth.
Usually their first dental visit should be by 1 year old.
Well, the reason it's kind of phrased when they have teeth is because some children don't have teeth at one.
Yeah, that's true. And some, but still we can look and at the gums, at the shape of the mouth, because a lot of times it's going to tell us if they're going to have any kind of problems with growth or narrow palates, different things like that. So we can still see stuff like that. But they don't get x-rays. I probably don't start x-ray until maybe 4 or 5,
That's a whole nother conversation.
unless they have problems, right? Unless they have problems like baby bottle syndrome So they need to come in so that we can educate the parents as well, because a lot of times the parent may leave juice in the bottle or milk in the bottle with the baby, and then the baby will start getting cavities on their front teeth. And that's a whole tragedy for some kids, because they have to go to a specialist and get put to sleep, get on that papoose board. It's traumatic. And then after that, you lost them. You know what I mean?
What
So
about
it's better for them to get.
And now we've got this whole drive to eliminate fluoride. So we got a whole nother dimension to the problem.
Yeah,
and what
that's
about
a problem.
what about pacifiers?
It depends on the shape of the pacifier. I'm not that, you know, I know that some pacifiers are good for the babies and some of them aren't. So it depends upon how it's shaped. So they have all these different, they have 1,000 different pacifiers. So that's a good question. I don't know.
Okay. Dr. Hines?
So there's a question I think that deserves some discussion. What do you recommend for, it says folks that don't have dental insurance? And I think the question, I lost it, but I think it was someone who said original Medicare and they don't have dental coverage. So then what?
Yeah. Medicare doesn't cover dental, but some of the Medicare Advantage plans, they have some dental coverage, but usually they're like HMOs. And HMOs do not do a thorough job of what I'm talking about. They are basic services. They will polish your teeth. They won't go down there and get that infection out. It's very rare that they would do something like that. So the best thing I could say is that they just have to make it a priority, because a lot of times, you know, people make things, if they know why they need it done, I think that more people would get it done, because it's way cheaper than a heart attack or a stroke, or, you know, and easier to keep your teeth clean than to have all these other consequences to your body. So if the more people know about how it affects their health, I think the more of a priority they'll make it. But there's just not a whole lot of options. And when you, as a senior, unless you had a job that still keeps you on their insurance, because usually like after 65 or so, some of these jobs kick you off of their insurance. And so insurance is not insurance, it's a benefit. I can tell you, one of my patients has insurance, and his crown was like $1,700. This is just like yesterday. The insurance paid $300 and he has to pay the rest. And he's a senior, he's 85 or 89. So it's like they really don't care. Like they don't. $300, you know, that's not even the lab. That's probably the lab fee.
Have you had much success? And then obviously every state's different, all that, got it. But with linking some of the medical conditions to the oral health need to kind of get coverage?
Well, they're only going to cover so much, and they don't even want to pay that. And so some insurances have actually even started covering more if they're diabetic. So they'll be like, oh, they get an extra cleaning. And some of them even in pregnancy, because pregnancy is another complication with oral health. And so they will cover extra cleanings during pregnancy too, because they can get pregnancy gingivitis. They can have pre-eclampsia. They have low birth weight, preterm babies, and all that's associated with oral health.
Well, I want to thank you so much for giving your time to us today and giving such an excellent talk. And I want to extend an invitation for you to come back in a few months. We need this again and more and expand it. I know you've got a lot to talk about. We have some final words we'd like to ask you for that you'd like to give us.
Well, I just would plead with you guys to incorporate that into your intake forms. Ask patients about their oral health, especially when they're dealing with high blood pressure, diabetes, and stroke patients, and also screen for sleep apnea. Excellent. That's what I would like to do. And if any of you need help doing that, just get in contact with me. And you can get in contact with me through Dr. Maxey, or if you wrote down any of my information, and I will be more than glad to help your office get, you know, the paperwork you need.
Do you have an electronic version of your folders?
No, I don't. I can mail them or deliver them if they're in the area. If they're out of the area, I can mail it.
Okay. All right. Dr. Lawson?
Very quickly, I just want those of you who read the book on Beautiful Mind, one of the first things the gentleman who had won a Nobel Prize in schizophrenia, the first thing he did when he got better was to go out and recover and get dental work done. And you talk about the difficulty you had in terms of getting some folks to do deep cleaning. It's impressive the extent to which people in mental health clinics have none. And the relationship with that and depression is well known, the upper severe is unknown. Just wondering what you can suggest to see who, and I'm sure Dr. Walsh said similar, which is how do you get people who are seeing primarily mental health clinics to get some sort of dental work done?
Oh, they definitely need a dental department, especially mental health care. Some of them is harder to they may need some sedation or something like that to get it done, but they definitely need need, because one of the signs of mental health is like their lack of oral hygiene. And then that could also be affecting their brain as well. So yeah, that needs to be addressed. That needs to be addressed.
Yes, Dr. Hines.
Well, I just want to thank you so much for just a wonderful and enlightening presentation. And I was really struck by what you said regarding the times that folks will see the dentist, but they're not getting the care that they need badly. As many times as we've heard that on this show, I don't know why I didn't think of it there too, but darn.
But no, it's true. It's really sad. It's really sad. But we have to do something about it, you know? So I don't know. It's a hard conversation to have too, especially with your friends or family. People don't like to mention, go get your teeth done, you know? And it'll lead you to a lot of people, if you notice, that had heart attacks probably had bad teeth. And I know a lot of people can think off the top of their head somebody, but if they just knew that information, that could have changed their outcome, you know?
Oh, for sure. And then the stories around things like, impacts on, mental decline to think, right? If we had cleaned your teeth better, would that have changed something? Like that's awful. That's traveling.
It is.
So Dr. Walks, your income is going to go down. I'm going to get some coconut oil. I don't have to pay anymore. Dr. Walks?
Dr. Mackey, I'm going to try to buy up all the coconut oil because I'm going to live a long time and I need it.
Right. Well, my grandmother just turned 103 and I clean her teeth probably like every 3 months, and she does do her coconut oil too. At first, she didn't want to do it because she didn't remember castor oil and stuff like that. So she was like, "Oh no, I don't want to do that." And I said, "Ma, I don't have a taste. Just taste it." And she had it right by her bed, so she do a tablespoon every day. And she still has her mental faculties.
Those of us who have been forced to use castor oil, remember, it'll scare you from anything else.
Right.
But no, Dr. Dixon, this has been, it is usually on Black Health Trust, we learn something that we can use. And I really celebrate Dr. Maxey for that, making sure that this is useful time for us. What you've done today is something a little bit different because you sort of opened a different door for us to look behind as general medical people. So I really, really appreciate that inter-health thing. It's so important. It just is. So thank you for that. I'm absolutely going to get some coconut oil. And and I also just want to make another comment. Most folks know that my older brother lives in Jamaica. I've got family there, and I was there once during a hurricane, and it's bad. Bad. It's a bad time when you don't have the same resources that we have here in America, and something devastating like that happens. So ongoing prayers for the folks in Jamaica, and ongoing thanks to you, Dr. Dixon, for an excellent presentation.
Thank you so much. My pleasure. It was my pleasure.
Dr. Barbara Davis Stevens?
Well, Dr. Dixon, again, thank you. And yes, I echo Dr. Maxey's invitation for a return visit to continue this conversation.
Okay.
And the thought that comes to my mind, based on what Dr. Hines said, is there is no shortage of work. So
Right.
nobody needs to start getting jealous or have their feelings hurt because somebody said or did something. There's enough for everybody. And my last word is please, please identify something and do what you can do because all we can do is what we can do.
Right.
Well, again, thank you so much for being with us. We want to pray for the people in Jamaica. Simon, is Brenda Lee Yeager on by any chance?
No.
Okay. Everybody have a great Sunday afternoon. Enjoy the rest of your day. And again, Dr. Dixon, thank you so much. Have a
Thank
great
you guys for having me. Have a good week. Have a good week, everybody.
Thank you,
Thank
Simon.
you.
Okay,
Bye.
bye-bye. Bye-bye.